Imagine your body going through a massive, like, completely overwhelming chemical shift.
Oh, yeah, a total system override.
Right. Picture waking up one day and your system is just flooded with almost 30 times its normal level of a specific, incredibly powerful hormone.
Practically swimming in it at that point.
Exactly.
Yeah.
Every single cell, every tissue is adapting to this incredibly high baseline. And then almost overnight, the plug is pulled.
Just completely gone.
Yeah, your body's suddenly drained of it. You're left running on fumes. So welcome to the deep dive.
It really is the ultimate biological whiplash. And honestly, it is a very precise description of what happens to a person's body immediately after childbirth.
It's wild. And today we are taking a stack of clinical trials, women's health clinic FAQs, and some expert pelvic floor physical therapy guides. And we're using all of that to answer a highly specific but incredibly common question for you, the listener.
It's a question a lot of people have but are afraid to ask.
So true. The question is this: can low estrogen during breastfeeding make laxity feel worse?
And, the short, resounding answer from the medical literature is yes. Absolutely.
It's just yes.
Yeah. And the science behind how that hormonal deficit physically alters the structural tissues of the body is, well, it's just a fascinating look into human biology.
I am so excited to get into this. This is such a vital topic. And honestly, I feel like it is so often brushed under the rug in postpartum care.
Oh, constantly. It's really frustrating for patients.
Right. Because for the new mothers out there listening, or, anyone just insanely curious about anatomy, you are often told to just expect things to feel different after giving birth. But we're going to look at the actual mechanics of why that happens.
The literal cellular changes.
Exactly. So to understand the changes during breastfeeding, we first have to look at the baseline. So during pregnancy, the body is in a hyperestrogenic state.
Very hyperestrogenic.
You have that massive surplus of estrogen coursing through your system for basically 9 months.
And that hormone is doing a tremendous amount of heavy lifting. It helps with fetal development, it preps the milk duct system, but crucially for this conversation, it keeps the vaginal and pelvic tissues incredibly thick.
Thick and, elastic.
Right. Elastic and very well supplied with blood. Estrogen is essentially the primary fuel source for maintaining the cellular integrity of that entire pelvic region.
Okay, so then the baby is born, or I guess more specifically, the placenta is delivered.
Yes, the placenta delivery is the key trigger there.
And that delivery is the trigger for the crash.
It is, because the placenta is, well, it's essentially a massive temporary endocrine organ.
Mm-hmm.
It acts as this dedicated hormone factory right there in the uterus for the duration of the pregnancy.
Oh, wow. I never really thought of it as a factory.
It totally is.
Yeah.
But once it separates from the uterine wall and is delivered, your systemic estrogen and progesterone levels fall off an absolute cliff, within a matter of hours.
That sounds exhausting.
It's a massive shock to the system. And simultaneously, the body has to ramp up production of a completely different hormone to take over the next phase of infant care, which is prolactin.
Okay, prolactin, that's the hormone responsible for stimulating breast milk production, right?
Yeah.
But it doesn't just, act in isolation. The sources were saying prolactin actively suppresses the ovarian production of estrogen and androgens, like testosterone.
It shuts them down.
Yeah, in order to maintain the milk supply, prolactin keeps those other hormones forcefully dialed down, which creates a state of hypoestrogenism.
Right. And from an evolutionary standpoint, that systemic suppression is a ruthless but biologically necessary calculation.
Ruthless is a good word for it.
It really is. The body is prioritizing the immediate survival of the newborn, right?
Mm-hmm.
Which means dedicating all available metabolic resources to lactation. So the physiological trade-off is that the mother's reproductive tissues are just temporarily deprioritized.
Okay, let's unpack this, because the analogy that came to mind when I was reading the sources, it's like a corporate takeover.
Oh, I like that.
Right. Prolactin is this aggressive new CEO who comes in, completely clears out the old C-suite estrogen and testosterone. They're fired. And the CEO redirects the entire factory's operating budget toward one single goal, which is milk production.
That is exactly what is happening. And while the new CEO is meeting those high production quotas for milk, the departments that rely heavily on estrogen are suddenly starving.
Which brings us to the pelvis.
Exactly. The vagina, the vulva, and base of the bladder, there's an area there called the bladder trigone, they are densely packed with estrogen receptors.
Okay.
So without their primary fuel, the physical architecture of that tissue fundamentally changes.
Which brings us directly to the physical sensation caused by that architectural change, which is vaginal laxity.
Right.
And I notice the research sources are very careful to define what we're actually talking about here. So vaginal laxity is defined as a patient-reported sensation. It's the feeling of looseness, a reduced sense of grip, or even air trapping.
Which is colloquially known as queefing.
Right, and the statistics show this affects up to 58% of new mothers 1 year after a first vaginal birth. That is over half.
It is incredibly prevalent. And, the clinical literature makes a really crucial distinction here. Laxity is not pelvic organ prolapse, or POP.
Okay, can you clarify the difference? Because they sound similar.
Sure. So prolapse is a measurable structural dropping of the pelvic organs, like the bladder, the uterus, or the rectum down into the vaginal canal. A physician can actually examine a prolapse and assign it an objective grade on a standardized scale.
Oh, got it. So it's a structural shift they can physically see.
Yes. But laxity is entirely a sensation of reduced tone and support.
But wait, if there is no objective medical test for laxity, like there is for a prolapse, couldn't a dismissive doctor just argue this is all in the mother's head? Like, she's exhausted, she just had a baby, she's recovering from major physical trauma. Maybe she's just hyperfixating on her body feeling different.
I'm so glad you brought that up because that is exactly the kind of dismissal many women face in clinical settings.
Which is awful.
It is. But the science completely refutes it. The sensation is very real because the tissue quality has objectively, physically degraded.
Because of the missing estrogen.
Exactly. To understand why, we have to look at what estrogen does at a cellular level. It is responsible for keeping the vaginal lining thick and moist. It maintains a robust blood supply.
Right.
It also feeds the healthy bacteria in the vaginal microbiome, like the lactobacilli, which keeps the environment acidic and protective.
So when you strip that estrogen away during the prolactin takeover, those cellular building blocks essentially just fall apart.
They do. Estrogen is basically the water in a sponge. When it's present, the tissue is bouncy, plump, and resilient. But prolactin comes in and just wrings that sponge totally dry.
Ugh, that sounds so uncomfortable.
It is. The collagen fibers, which provide the structural scaffolding and strength of the tissue,
Sure.
they begin to fuse together. And the elastin fibers, the ones that give the tissue its stretch and mechanical recoil, they literally fragment and break apart.
They break apart. Wow.
Yeah. The mucosal lining transforms from this thick, robust barrier into a layer that is visibly thin, dry, and fragile. It often becomes friable, which means it can easily tear and bleed under, minimal friction.
Okay, so when the mechanical stretching of childbirth happens, the tissue recovering from that stretch isn't a bouncy, well-lubricated rubber band anymore. Because of the breastfeeding hormones, it's like, I don't know, pulling on a dry, brittle piece of elastic that has been left out in the sun.
That is a perfect way to visualize it. The mechanical stretching from a vaginal delivery causes microtrauma to the levator ani muscles in the pelvic floor.
And muscles need blood flow to heal.
Exactly. Those muscles need robust blood flow to recover. But the breastfeeding hormones are actively starving the area of the very estrogen needed to provide that healing blood flow and elasticity.
So it's a double whammy.
It really is. We have stretched, fatigued muscles wrapped in thinning, inelastic mucosal tissue. The two factors compound each other heavily.
And this physical degradation of the tissue perfectly mirrors another major life phase, doesn't it? The sources highlight a newly coined medical framework for this, genitourinary syndrome of lactation, or GSL.
Yes, GSL.
Yeah.
The terminology was proposed recently to bring actual clinical awareness to this specific postpartum population. Because, their symptoms directly mirror a much more widely recognized condition.
Which is genitourinary syndrome of menopause, or GFM.
Right.
And reading through the sources, the symptom profiles of GSL and GSM are nearly identical. We're talking about a vaginal environment that feels like Sahara Desert dry.
Very dry.
Significant pain with intercourse. The medical term they use is dyspareunia plus micro-tearing of the tissue and frequent urinary urgency. I mean, young women in their 20s or 30s are essentially being thrust into a temporary localized menopause.
It is wild when you think about it. And the sheer power of that hormonal deficit becomes really clear when we look at the clinical data. What do the numbers look like? Well, in a typical postmenopausal woman, circulating levels of estradiol, which is the most potent form of estrogen, they hover around 18 picograms per milliliter.
Okay.
Now, in a woman who is exclusively breastfeeding, those levels sit just slightly higher, typically between 30 and 40 picograms per milliliter.
Wow. And just to give you, the listener, an idea of how microscopic these amounts are, a picogram is 1 trillionth of a gram.
It is an unbelievably small measurement.
Yeah, we are talking about trace drops in an Olympic-sized swimming pool. But the difference between those drops dictates the entire structural architecture of the pelvic region.
Because the vaginal tissue doesn't care about a patient's biological age.
Mm.
It only responds to the circulating hormone levels it currently receives.
Right, it doesn't know you're 28, it just knows it's not getting estrogen.
Exactly. And that severe drop to 30 or 40 picograms is more than enough to trigger major atrophy-like symptoms. And I have to say, the psychological toll of this is profound.
Well, yeah, nobody warns you about the temporary menopause.
No, they don't. Women experience this profound dryness, the pain, the physical sensation of looseness, and they internalize it. They think childbirth permanently ruined their anatomy.
That is so heartbreaking.
It is. They suffer in silence due to shame, assuming they are fundamentally broken. So reframing this as genitourinary syndrome of lactation is huge. It allows patients to realize they're fighting a temporary, completely natural menopausal state.
Driven entirely by the mechanics of feeding an infant.
Right. It is a biological response, not a permanent structural failure.
Shifting the blame from my body is broken to my body is just temporarily redirecting resources has to be a massive relief.
A total game changer for mental health.
So if the problem is a combination of a stretched muscular hammock from birth and starved thinning tissue from breastfeeding, we can logically map out a dual approach to fixing it. Like, you can't just treat one and ignore the other.
No, you really can't.
We have to rehabilitate the muscle tone beneath the surface before we can expect the delicate tissue above it to feel fully supported.
Precisely. And the clinical consensus unanimously points to pelvic floor muscle training, or PFMT, as the first-line care for the muscular component.
And this goes far beyond casually doing a few Kegels at stoplights.
Yeah, absolutely. It requires targeted rehabilitation, ideally guided by a specialized pelvic floor physical therapist.
Yeah, the sources make a huge point about how doing Kegels incorrectly can actually exacerbate the feeling of laxity and pain, which sounds so counterintuitive.
It does, but it happens all the time. Many postpartum women develop hypertonic pelvic floors, so the muscles become too tight, basically locking into a chronic spasm.
Why does that happen?
It is often a subconscious guarding response to pelvic pain or perineal tearing, or just the trauma of delivery in general.
Okay, that makes sense.
So if a patient with a hypertonic pelvic floor is prescribed endless, contracting Kegel exercises, the muscle fatigue and pain will only increase.
It's like having a severe cramp in your calf and trying to fix it by doing endless calf raises.
That is exactly what it's like. You have to learn how to stretch and relax the muscle first. A skilled physical therapist will utilize the diaphragm to teach this relaxation. The diaphragm and the pelvic floor work like a piston system in your core.
Oh, I love that imagery.
It's very mechanical. When you take a deep inhale, the diaphragm pushes down, and the pelvic floor must physically lengthen and relax to accommodate that pressure. When you exhale, the diaphragm rises, and the pelvic floor naturally lifts.
So rehabilitating that full dynamic range of motion is what rebuilds the underlying structural support.
Exactly.
Okay, so once the muscular foundation is being addressed, we have to look at the surface tissue itself. That thin, dry, estrogen-starved mucosal lining. Hydration is the most immediate step, right?
Always start with hydration. Lactation demands an enormous amount of fluid from the mother's body, so simply increasing your water intake helps systemic hydration.
But for local comfort, the literature suggests water-based lubricants for intimacy and non-hormonal daily moisturizers.
Yes. Ingredients like hyaluronic acid or vitamin E oil applied topically to the vulva and lower vagina can provide significant relief.
Hyaluronic acid is everywhere in skincare right now.
It really is, and it's particularly effective here because it acts as a humectant. It's capable of holding up to 1,000 times its weight in water.
Wow.
So it binds moisture directly into the cellular matrix of the tissue, which reduces that daily friction and prevents those painful microtears.
But, if lifestyle changes and moisturizers aren't enough to reverse the symptoms of GSL, there is a medical intervention that targets the exact root cause, which is local vaginal estrogen.
Yes. And honestly, this is often the turning point in postpartum recovery for a lot of patients.
How is it applied?
It is prescribed in the form of low-dose creams or localized pessaries or even flexible silicone rings that are inserted directly into the vaginal canal.
Well, wait, I have a question about this. If prolactin is intentionally suppressing estrogen to protect the milk supply, wouldn't introducing a medical estrogen completely disrupt that biological priority? Like, will it tank the mother's milk supply or pass harmful hormones to the baby?
That concern is incredibly common. among both patients and even some general practitioners.
I mean, it seems logical to worry about it.
It does. However, the specialized medical consensus in our sources confirms that local vaginal estrogen is considered highly safe for breastfeeding mothers.
Okay, so why is a local application safe if systemic estrogen, like a traditional birth control pill, isn't?
It all comes down to how the circulatory system interacts with the vaginal mucosa.
Okay.
When you apply a low-dose estrogen directly to the vaginal tissue, it binds immediately to those dense local estrogen receptors we talked about earlier.
Right, the ones that are starving.
Exactly.
Hmm.
It goes right to work, plumping the cells, stimulating collagen synthesis, increasing localized blood flow, and restoring the acidic pH. But the systemic absorption, meaning the amount that actually crosses into the main bloodstream, is incredibly low
Oh, I see.
because it doesn't meaningfully spike the circulating estrogen levels in the blood. It does not transfer into the breast milk, and it does not signal the brain to drop the milk supply.
That is fascinating. You are basically biohacking the localized tissue to heal itself without triggering the systemic alarms that would disrupt feeding the baby.
Exactly right.
Now, I did notice the sources also bring up vaginal rejuvenation devices, so things like fractional CO2 lasers and radiofrequency wands that claim to tighten tissue.
Yes, and this is where we have to be very careful. Global medical regulators are actually stepping in and hitting the brakes on those energy devices.
Really? How are they supposed to work?
Well, they theoretically work by causing controlled thermal microinjuries to the vaginal wall. The idea is that this stimulates the body's natural healing response and produces fresh collagen.
But wait, causing microinjuries to tissue that is already starved, thin, and friable? That sounds like a recipe for disaster.
It can be. The FDA in the United States, along with regulators in the UK and Australia, have issued safety warnings and canceled routine approvals for these devices specifically for treating laxity.
Wow, okay.
Yeah, there simply isn't enough robust, long-term evidence proving they are safe or effective. And the documented risks include severe burns, scarring, and chronic pain.
Oh, that's terrible.
It is. Conservative, evidence-based physical therapy and localized hormone support is absolutely where clinical treatment should start.
Okay, so for a mother listening to this who plans to exclusively breastfeed for, say, a year or more, what does the timeline look like? Does she just have to endure this compromised tissue state until the baby is completely weaned?
She absolutely does not have to endure it. I mean, natural, unassisted improvement will typically kick in as breastfeeding frequency reduces and the menstrual cycle naturally returns.
Because ovulation brings the estrogen back.
Exactly. When ovulation resumes, the ovaries wake back up and resume producing systemic estrogen. But you do not have to wait for that natural systemic reboot.
Right.
Engaging in targeted pelvic floor therapy and utilizing local vaginal estrogen can dramatically reverse the sensation of laxity, the dryness, and the pain while you are still actively lactating.
That is so empowering. Taking something that feels so vague and terrifying, this pervasive thought that your body is permanently ruined, and breaking it down into a highly treatable mechanical and chemical equation.
Understanding the underlying mechanism of genitourinary syndrome of lactation strips away the shame. Recognizing it as a temporary, hormonally driven state is the first step to actively reclaiming your comfort and quality of life.
I love that. So to bring everything we've covered today into focus for you, the listener, vaginal laxity is a real, measurable physical sensation. It is not something you are making up in your head.
Not at all.
It is heavily exacerbated by the profound estrogen crash required for breastfeeding, which temporarily degrades the collagen and elastin in your connective tissue. That degradation makes the mechanical stretching of childbirth feel significantly less supported.
Exactly.
But it is entirely treatable through a dual approach. You rehabilitate the muscles underneath with breath-led physical therapy, and you repair the surface tissues with targeted hydration and safe, localized estrogen.
It perfectly illustrates how interconnected our biological systems are. I mean, you cannot evaluate the structural integrity of the pelvis without understanding the endocrinology of the whole body.
Which brings me to a final thought to leave you with, the listener. Something to mull over as you go about your day.
Oh, I'm curious.
So, if our pelvic connective tissues are so incredibly sensitive that they fundamentally change their elasticity, their thickness, and their bounce based on the temporary hormonal demands of breastfeeding, what other subtle structural changes are happening in our bodies every single month?
Oh, wow. The implications for general female biomechanics are vast there.
Right. Think about the natural hormonal fluctuations of a standard menstrual cycle. Your estrogen levels rise and fall in a predictable wave every month.
Mhm.
We already know that female athletes experience higher rates of ACL, tears in their knees during specific phases of their menstrual cycle when estrogen drops.
Yes, the data on that is really clear.
So, could our baseline feeling of physical strength or laxity, and not just in the pelvic floor, but in our joints, our ligaments, our entire structural scaffolding, could that be shifting week by week without us even realizing it?
If a chemical shift can completely reshape the architecture of the pelvic floor after birth, we are likely constantly rebuilding and adjusting the tension of our connective tissues month after month.
We are not static structures. We are dynamic chemical ecosystems. It definitely changes how you think about that overwhelming hormone shift we talked about at the start.
It really does.
Well, keep questioning, keep learning, and keep diving deep.